Good day everyone. Hi, I am Reina May Juarez from BSN A1, NARS May for short. And for today's video, I'll be doing the head-to-toe assessment return demonstration. So our head-to-toe assessment will be divided into 4 different segments. Segment number 1 will be all about the head and the face of the patient. So we are going to assess the patient's ears, eyes, nose, and mouth. The segment number 2 will be all about the neck, the respiratory, the posterior, anterior, and chest of the patient. Then our third segment will be all about anterior chest, cardio, upper extremities, and abdomen. Then our fourth segment will be all about lower extremities and the different neurologic examination. To make our procedure efficient as possible and to minimize the position changing of the patient, we are going to use the systematic approach that proceeds through one region to the next in an orderly sequence. In this video, the patient has normal findings. Also, to avoid repetition, we are going to use one technique or test performed on one just side of the patient's body. In real life setting, of course, we are going to repeat it on the other side as needed as possible. To start our assessment, we are going to get the patient's health history to obtain subjective data. The information that we gathered will provide insights to the potential health problem of the patient and guide our physical assessment. In taking the patient's history, we are going to start with an open-ended question. This is to let the patient speak freely. But if you want a specific information, you can use a direct question. Note the consciousness level of the patient as well as the orientation to person, place, and time of the patient. After, we can ask the patient to empty his or her bladder and to put on a gown. While the patient is changing, the first step that we are going to do is to gather the equipments we will need for the assessment. Wash or sanitize our hands, and then warm our equipments. In assessing the patient, we are going to use the 4 basic techniques. These are the inspection, palpation, percussion, and auscultation. And then, if the patient is already finished changing, we are now going to explain the assessment process to him or her. The next thing we are going to do is to drape the patient appropriately. Exposing the area only examine. Follow a logical sequence. Compare both sides of the body and examine the skin throughout. To start the assessment, we must first get the height and weight of the patient. So assuming we already measured the height and weight of the patient, the next thing we are going to obtain is his vital sign, starting with his temperature.
Then we are going to check the patient's radial pulse as well as his respiration for 1 full minute. And then of course the patient's blood pressure. And of course, never forget to tell the patient and document your findings. Now we are ready to assess the patient's head and face. First, we are going to inspect the head, face, and note that they should be normal in size, shape, symmetry, and contour. Then we are going to check the patient's hair and note its distribution, quantity, texture, and color. Next, we are going to palpate the patient's scalp. Then using the tips of our middle finger and index finger, we are going to palpate the temporal arteries. Note that they should be equal. Then we are going to listen for bruise. Now we are going to press our thumb under the inner aspect of the orbits to palpate the frontal sinuses and press under the zygomatic bones to palpate the maxillary sinuses. Then we are going to lightly percuss these areas. Now we are going to move our fingers to the temporal mandibular joints as we palpate with our middle finger and instruct the patient to open and close his mouth. The joint should move freely and painlessly. To test the patient's facial muscles and the motor portion of the facial and trigeminal nerves, we are going to instruct the patient to raise and lower his eyebrows, bare his teeth, smile broadly, puff out his cheeks, and keep his mouth closed as we try to open it. All of these movements should be symmetrical. If the patient reported problems with his sense of taste during the health history interview, we are going to test the sensory portion of the facial nerve by having him identify sweet, sour, bitter, or salty substances. To assess the sensory portion of the trigeminal nerve, test the patient's ability to identify simple touch. Instruct him to close his eyes and tell us the moment something touches his skin. Check for simple touch sensation on both sides of the patient's forehead, cheeks, and jaw. The patient should feel the sensation on each side equally. Now, we are going to test the patient's eyes. But first, we are going to test the patient's visual acuity with a Snellen eye chart. Then, instruct the patient to stand 20 feet from the eye chart and keep both eyes open. Cover the one with guard and read it loud, the smallest letter where he can read. Note the line's numerator, 20. This is the patient's distance from the chart. Also the denominator, which is the patient's normal vision. And then record the patient's vision from each eye. Now we are going to inspect the patient's eye and externalize structures. The eyes should appear symmetrical and the eyebrows should be free from skating. And the upper eyelids should partially cover the iris and the eyelashes should turn outward. Now we are going to test the oculomotor nerve by asking the patient to close his eyes. The eyelids should move symmetrically without tremors. Gently palpate the eyelids for nodules or tenderness. Then ask the patient to open his eyes and look up as we invert the lower lid to inspect the lower conjunctiva. Then have the patient look downward as we pull up his eyelid to inspect the upper conjunctiva sclera. Palpate the lacrimal apparatus by gently pressing below the orbit. Pressure should not produce exudate. Next, we are going to check the patient's extraocular movements to assess extraocular muscles and innervation of the ocular motor, tricular and abducens nerve. Now we are going to place our finger 12 inches from the patient's eyes and instruct him to follow our finger as it moves to the upper right, far right, lower left, far left, and upper left. The eyes should move together equally and smoothly through these 6 cardinal positions of gaze. To test accommodation, we are going to hold our finger 4 inches from the patient's nose, then ask him to look at our finger at the wall behind us and back to our finger. Then we are going to perform the cover and uncover test. While the patient stares at the wall behind us, we are going to have him cover one eye with a card, then observe his uncovered eye. It should not wander or move. When he move the card, we watch the eye he just uncovered. It should not wander or move. Inspect the patient's cornea and lens for opacities. Then test his corneal light reflex. To do this, we are going to instruct him to stare straight ahead while we shine a light on the bridge of his nose from 12 inches away. Note that if both cornea reflects the light in the same spot, the eyes of the patient are properly aligned. Then, we are going to inspect the patient's pupils. Normally, they are 3 to 5 millimeters wide and equally round. Also, we are going to check the patient's pupillary light reflex, which assesses the optic and oculomotor nerves. To do this, darken the room and shine one light on one pupil from the side. Normally, this causes both pupil to constrict. Document these findings as perla. which means pupils equal and round, reactive to light and accommodation. The first thing we are going to do is to prepare the ophthalmoscope by selecting the lens size, turning on the ophthalmoscope and adjusting the aperture to find the largest beam of light. To examine the patient's left eye, we are going to hold it in our left hand with our index finger on the lens select. Then instruct the patient to look at the fixed point straight ahead and to keep his eyes still. Then we are going to approach him from 15 inches away and add an oblique angle, then focus a small circle of light on his pupil. Keep looking at the red reflex as we move toward the patient. As the retinoidal becomes sharper, follow the blood vessels until they converge at the optic disc on the nasal side of the retina. Use 1 disc diameter or DD as the basis for measuring any retinal background lesions and use clock face to indicate the lesion's location. Also, we must observe the physiologic cap, which should be half the side of the disc. The retinal vessels, which should appear as a pair, a vein plus a higher, thinner arterial. The fundus, which should appear light red to brown red, and the macula, which should be about 1 disc diameter temporal to the optic disc and should contain no blood vessels. Remember to always inspect the macula last. Now we are going to assess the patient's ears. First, we are going to inspect and palpate the ears. They should be symmetrical with no swelling, lesions, thickening, or pain. Now we are going to palpate the mastoid process behind the ear. This should not cause tenderness. Next, we must prepare to perform the otoscopic exam. To examine the patient's ear, we must hold the otoscopic in our dominant hand between our thumb and fingers. Pull the pinna of the ear up and back to straighten the ear canal. Remember to look in all directions to view the entire tympanic membrane. Now we are going to inspect the external ear canal, then examine the tympanic membrane or eardrum. Note the malleus, light reflex, and the incus. Finally, we draw the speculum, and if we see exudate, we are going to change the tip. Next, we'll assess the patient's hearing by performing the voice, the Weber, and the Rins test. For the voice test, gently occlude one of the patient's ear with our finger, then test the other ear as we stand 1 to 2 feet away from him and gently wiggle our fingers in his ears as we whisper a 2-syllable word. He should be able to repeat those words. Then we'll perform the Weber's test. To assist the sound transmission through the skull bones, we'll need to use the tuning fork in this test, a 512 to 1024 Hz. We must hold the turning fork and strike it in our palm. Place the stem of the vibrating turning fork in the midline of the patient's skull. Then the Raynaud's test, which can detect if the patient has a conductive hearing loss. Then we'll strike the turning fork again and place its stem on the mastoid process. Count the second until the patient can no longer hear the sound. These indicate bone conduction. Then immediately place the still vibrating turning fork close to the patient's urethral, and count the seconds again until the patient can no longer hear the sound. These indicate ear conduction.